Hello, so I wanted to talk about all of the point A, B, H, M, and P in the cervical brachy system, cervical ICBT system. But before that, how did we come to this and what do we practice now? So, cervical brachytherapy, as we know, it's the ICBT and ISBT. IC is intracavitatory, IS is interstitial. For ICBT, we have three systems. It was introduced, Stockholm was introduced in 1910s, Paris in 1920s, and Manchester 1930s. So let us just briefly know what the differences between all of these is. So Stockholm system is a fractionated system. Paris is like only one fraction, single application, and Manchester is again a fractionated system. So Stockholm system, this was originated before. So the thing is, originally we used to use radium as the source, and they used to preload it at that time. Then the after loading system came, right? So preloading system where the radium was supposed to be used at that time. So for fractionated therapy, they used to use intrauterine sources of the radium, and intravaginal they used to keep. So there used to be no connection between these two. So you can see here, as if I zoom it, these are the intrauterine tubes that they used to keep it here, and these are the flat plates that they used to keep in the vagina, like that. So the similar images here, these are the intrauterine tubes that they used to keep, and this is the flat box in which they used to keep the vaginal sources. And the similar image here, this is the vaginal and this is the intrauterine source, and this is the packing done here. So the sources that they used to keep was like unequal. The radium in the intrauterine used to be like 30 to 90 mg of radium. In the intravaginal, it used to be 60 to 80 mg of radium. And since it is fractionated, so they used to give 2 to 3 fractions of treatment, each of a period of 20 to 30 hours of each fraction, and it was separated by 1 week. So it used to go so long. Now next, coming to PAR system, this was introduced in 1920s, where it was a uh, single application treatment, and here it is used to be 120 hours of treatment in 5 to 8 days. Now here what you could see here, in the Stockholm system, the doses were unequal, right? Comparing the intravaginal and the intrauterine and the intravaginal, here it used to be equal. So whatever the amount of radium that you put in the intrauterine and the intravaginal used to be equal, but intrauterine tubes, the ratio used to differ. Now you can see the green line is bigger in the upper two and it's shorter in here, right? So it was like 1:1:0.5. That is the intrauterine tubes, intrauterine sources. And vaginal, there used to be colpostats or corks. That was the vaginal source that they used to use. This used to be kept in the rubber tubes. Similar image, this is the U-shaped uh, ring connecting the two vaginal sources, and these used to be the intrauterine sources. Now what happened is, at this time, like when they were using radium, it was calculated that treatment time was fixed. I mean, sorry, it was fixed in mg/hours. So they used to keep for so many hours of treatment. They used to not calculate like at what point dosimetry at that point was in mg/hours. So according to Stockholm, they used to give around 6,500 to 7,100 mg/hours. According to Paris, they used to give 7,200 to 8,000 mg/hours. Now apart from radium, if they used like other substances like cesium, iridium, all of that, so at that time they used to calculate as radium equivalent mg/hours. Okay. They used to not calculate point wise, but when the Manchester system came in 1930s, Manchester system is a fractionated treatment. So it used to be given in two fractions, into fraction 1 week apart each, and each treatment used to last for 72 hours. So this is the rubber tube that they used at that time, and these are called the ovoids, tandem rubber tubes in which they used to keep the intrauterine source. This is the ovoids. Now they used to Todd and Meredith in 1938 used to follow the point based system, because and the dose was calculated in Röntgen at various points, so that they can compare patient to patient basis at that point how much dose is going. So but they want, how do they calculate that? The limiting point can be vagina or the rectum or the bladder. So the limiting point was point A. Now what is that point A? Is the point A refers to this triangle. You can see this triangle over here, this triangle. So how is this triangle formed? This triangle is formed medially by the uterine body over here, and laterally by the ureter, and apex is formed by the uterine vessels over here, uterine artery. So this apex is point A. It's a pyramidal shaped triangle, that is paracervical triangle. This is paracervical triangle. Okay, this is where the point A is situated. So this is the limitation point and also the prescription point, so that here also if the dose is more, here this is the point where most of the radiation necrosis is seen. Now what exactly is point A, and how do we define that? Now point A also has original point A, and there are some subdivisions of point A's. Now let us see that each. So what is point A? Point A, according to the original Manchester system, it used to be that the mucous membrane, the lateral fornix mucous membrane at that level in the central along the axis of the tandem, 2 centimeters above to that and 2 centimeters laterally used to be our point A. So that was the original definition of point A, but this was anatomical. Anatomical is what is required, but when they used to do radiological things, they could not see it in the radiographs. That's why there was a modified or a revised point A that was formed in 1953. So this gave us from the flange or from the os, from the point of the os 2 centimeters above, and 2 centimeters above along the tandem, and 2 centimeters lateral. That used to be our point A. That was the modified point A. Now the point B is also there. So this was point A, right? Point A is 2 centimeters above and lateral to the lateral fornix mucous membrane of that. Point B is 3 centimeters lateral to the point A, but if the axis of but point B is with respect to the midline of the body. So if there is a uterus which has turned a bit, like a patient who's, like in this case you can see the uterine axis is different. So the point A is with respect to the uterine axis, 2 centimeter above and 2 centimeter lateral, that is point A. But point B is with respect to the midline of the body. This is the midline and this is the point B. Now what does point B represent? So point A, we said that it is representing paracervical triangle, and that is also the limitation point. Now what is point B? Point B is representing obturator nodes. Obturator nodes. There is also like only point A and point B which are important, but there are also some other points which are mentioned in the as your use of the books. What is point P is? Point P is 6 centimeters lateral to the central axis. So here central midline, this is 5 centimeters, right? 5 centimeters is point B. If it is 6 centimeters, this is point B, and this represents the lateral most point of the and this is also where the lateral pelvic wall is there. So this is the lateral most point, this is point B. Now we discussed original point A, we discussed modified point A and point B and point P. Now what is point H and point M? Point H is according to American Brachy Systems, American Brachy Society. So point H is, so in this image you can see point A naught is the original one, original point A, and AF is the modified point A. So A naught is, they have represented both A naught and AF here. I'll show that first over here. So this 1.2 centimeters above and 2 centimeters lateral to that is this one is point original point and the modified point. Now I'll just straightly come to the point H. Point H is when they add the radius, see they are adding the radius of the ovoid from that point 2 centimeters above, and from that point 2 centimeters lateral. This will be your point H. And I'll tell that again just to clear. So this is the radius of the ovoid. From that point take 2 centimeters above and 2 centimeters lateral, that will be point H according to ABS. Now what is point M? Point M is, if you take this radius as 1 centimeter, then it will be point M. So that is 1 centimeter plus 2 centimeters plus 2 centimeters, this will be point M. This is according to Madison system. Okay, so this is done. What is bladder and rectal points? Bladder point is when you inflate the bladder balloon with the catheter balloon with the 7 ml or 7 cc of the fluid. The posterior most point perpendicular to it, perpendicular central one, this will be the bladder reference point, and 0.5 centimeters from the posterior vaginal wall to the rectal wall, this will be the rectal reference point. Now for lymph nodes there is Fletcher's trapezoid. Okay, so first how do we come here? So here we have to mark the L5 at the L5 midpoint, and here this is S2 S3 junction, and this is pubic symphysis. Join a line from S2 S3 S1 S2 to pubic symphysis. To the midpoint of this you need to join a line from L4 till this, to the midpoint of it. So at this point you need to come to the AP. At this point you have to come 6 centimeter each, mark that point, and in the L4, at the body of the L4, 2 centimeters from the midline on each side, this will be this, again mark those things and connect these two marks that you have done, 6 centimeters this side, 2 and 2 centimeters above, and this you have to connect and mark the midpoint of it. Now what all of these points represents is, the lowermost points represent the external iliac lymph nodes, and the middle point represents the line joining that, and the middle point represents the common iliac lymph nodes, and the upper ones indicate the para-aortic lymph nodes. So the doses to these regions are marked based on lymphatic trapezoid or Fletcher's trapezoid. There are some drawbacks of point A. So as you can see in these two images, a person who has a small uterus, a person who has a big uterus, and if you mark this and you prescribe the dose to this point, what is the disadvantage? In a person who has a small uterus, you just put 2 centimeter above, 2 and 2 centimeter lateral to the flange, right? So at that point it is going beyond what is required for us. So here it is, here you are overdosing, here you are underdosing. So here still there is a cervix which is beyond the point where you have to prescribe. You have to prescribe at the paracervical triangle, right? So now it is inside of that. So here there is underdosing, here there is overdosing. So that's the drawback of point A.